The last virus family that we're going to talk about in this course is the herpes viridae. This family includes hundreds of viruses of mammals, birds, reptiles, even fish and bivalves. Herpes viruses are a leading cause of human viral disease, second only to influenza and cold viruses. They're capable of causing overt disease or remaining silent for many years only to be reactivated. So think, for instance, shingles. The name herpes comes from the Latin herpes, which in turn comes from the Greek word herperin, which means to creep. This reflects the creeping or spreading nature of the skin lesions caused by many types of herpes viruses. The herpes virus genome consists of a non-segmented, linear, double-stranded DNA molecule. Genomes encode for as many as 200 genes. The virions consist of an envelope, a tegument, a nucleocapsid, and a core. The virions are 100 or more nanometers in diameter and may be spherical to pleomorphic in shape, with numerous evenly dispersed glycoprotein surface projections. The tegument, which is the structure between the envelope and the nucleocapsid, does not display distinctive features, but contains at least 14 viral proteins. The round nucleocapsid exhibits icosahedral symmetry and is approximately 100 nanometers in diameter. Viral DNA is located in the core of the mature virion in the form of a torus. The torus may be suspended in the capsid by fibers anchored to the underside of the capsid shell. Herpes viruses are known to share 6 hallmark characteristics: ubiquity, latency, incurability, reactivation, unapparent infection, and opportunistic infection. Most herpes viruses are very host-specific. They are well adapted to their hosts, and their lifestyle is to remain within an infected host for life. Many herpes virus infections are asymptomatic. Occasionally, however, herpes viruses can cause severe systemic and/or central nervous system infections. Neonates and the immunocompromised are at the highest risk for severe infection. There are also clear associations between some herpes viruses and cancer. One of the most important characteristics that you see on this slide is the ability to remain latent. That provides a mechanism for the virus to survive in the human population. It provides them the ability to reactivate at a site suitable for transmission to uninfected individuals. The family Herpes viridae is divided into 3 subfamilies: the alpha, the beta, and the gamma herpes viruses. And we'll look at all of these in the coming slides. So when we look at these 3 subfamilies, we can see that they do have differences in biological properties. So for instance, with the alpha herpes viruses, that includes herpes simplex virus and varicella zoster virus. We see a variable host range, short replication cycles, rapid spread in culture, followed by destruction of the host cells, and the virus remains latent in sensory ganglia. With the beta herpes viruses, that's CMV and HHV6, you have a restricted host range, a long replication cycle, slow progression in culture, and like all herpes viruses, we see latency, but in this case, latency occurs in monocytes, macrophages, and memory B cells. And then with the gamma herpes viruses, has Epstein-Barr virus in the group. Again, there's a restricted host range. They replicate in epithelial cells and lymphocytes, and they're, they are latent in lymphoid tissues. So, although all of the herpes viruses share some biological characteristics, the three families can be divided up based on these differences that we just went through. There are four properties that characterize the life cycles of members of the herpes viridae. First of all, herpes viruses express a large number of enzymes involved in metabolism of nucleic acid, DNA synthesis, and the processing of proteins. Second, the synthesis of viral genomes and assembly of capsids occurs in the nucleus. Third, productive viral infection is accompanied by inevitable cell destruction. And lastly, herpes viruses are able to establish and maintain a latent state in their host and reactivate following cellular stress. So now let's look at the basic productive viral life cycle. Cellular attachment of herpes viruses occurs by the binding of viral glycoprotein spikes to one of several host cell receptors. Following attachment, the viral envelope fuses with the cell plasma membrane, the nucleocapsid enters the cytoplasm, and the DNA protein complex is then freed from the nucleocapsid and enters the nucleus, quickly shutting off host cell macromolecular synthesis. There are three classes of messenger RNA, alpha, beta, and gamma, and they are transcribed in sequence by cellular RNA polymerase II. The alpha proteins initiate transcription of beta messenger RNAs, the translation of which produces beta proteins and suppresses the transcription of further alpha messenger RNAs. Viral DNA replication then commences utilizing some of the viral alpha and beta proteins in addition to host cell proteins. The transcription program then switches again, and the resulting gamma or late messenger RNAs are transcribed from genes found throughout the genome and are translated into gamma proteins. Many of the alpha and particularly beta proteins are enzymes and DNA binding proteins, whereas most of the gamma proteins are structural. Intricate controls regulate expression at the level of both transcription and translation. Viral DNA is replicated in the nucleus, and newly synthesized DNA is translocated into preformed immature capsids in an energy-dependent process. Maturation involves the completion of encapsulation of virion DNA into nucleocapsids and the association of nucleocapsids with specialized patches of the inner layer of the nuclear envelope, where a subset of viral proteins accumulate. Primary envelopment occurs by budding of capsids through the nuclear membrane, and primarily envelope virions are present in the endoplasmic reticulum, out of which they are released by fusion with the outer nuclear membranes. This process releases naked nucleocapsids into the cytoplasm. Secondary envelopment takes place at Golgi and endosomal vesicles, in which mature virions accumulate and are finally released by exocytosis. So what you see here is that the virus actually buds twice. One internal budding, and then out of the nucleus, and then you have fusion entry into the ER, and you have budding out of those membranes. The virus-encoded membrane proteins are also found in the plasma membrane, where they're involved in cell fusion. They can act as Fc receptors and are presumed to be targets for antibody-mediated cytolysis. Herpes viral infections persist for the life of the infected host, due in large part to the ability of these viruses to enter a non-productive latent state in which viral gene expression is limited and immune detection and clearance is avoided. Periodically, the virus will reactivate and enter the lytic cycle, producing progeny virus that can spread within or to new hosts. Each subfamily of herpes virus has evolved its own unique ecological niche within the host that allows for the maintenance of latency over the life of the individual. So, for instance, with the alpha herpes viruses, which are neurotropic, they become latent in the neural root ganglia and reactivate to produce epidermal ulceration, either localized, as we see with herpes simplex type 1, or spread over several dermatomes, like we see with varicella zoster or shingles. Human cytomegalovirus, which is the prototype beta herpes virus, establishes latency in bone marrow derived myeloid progenitor cells. Reactivation of latent virus is especially serious in transplant recipients and AIDS patients. Lymphotropic gamma herpes viruses, like Epstein-Barr virus, reside latent in resting B cells and reactivate to produce various neurologic complications. Maintaining a latent infection requires that the viral genome be perpetuated and the cell be kept alive. So let's look at how HSV1, herpes simplex 1, does this, because it's probably the best studied in this group of viruses. It's a neurotropic virus, and remember, neurons are non-dividing, so the virus doesn't have to worry about genome replication and faithful partitioning to daughter cells upon division. So that's not an issue for latency for herpes simplex 1. Now, perhaps to avoid cell death by apoptotic or immune measures, HSV1 severely restricts viral gene expression during latency. The major transcript, in fact, the only transcript that's detected, is called the LAT, for latency associated transcript. LAT is thought to be processed into microRNAs or miRNAs that have the potential to translationally silence mRNAs that encode for the viral immediate early genes. Suppressing the IE genes prevents the lytic replication cycle. Nerve growth factor, or NGF, induced signaling also helps maintain latency in vitro. Stress signals induce the recruitment of VP16 into the nucleus. VP16 is a tegument protein of HSV1 that can activate the transcription of viral immediate genes. Its delivery into the nucleus leads to the activation of viral IE gene expression, and then a productive reactivation event will follow. Okay, so now let's go through some of the most common herpes viruses that affect humans. HSV1 typically infects the lips and mouth, causing oral herpes or cold sores to develop. It's an extremely common virus that's usually transmitted in childhood, usually through contact with a parent or other family member that has the virus. A majority of people around the world are infected with HSV1, and many people are asymptomatic, meaning that they carry the virus and can potentially spread it to others, but don't have any visible, obvious symptoms. HSV1 usually causes outbreaks of herpes around the mouth, and between outbreaks, the virus is dormant in the sensory ganglia neurons, a group of nerve cells near the ear. While HSV1 usually affects the lips and mouth, it can also spread to the genitals and result in genital herpes. HSV1 usually spreads to the genitals through oral sex and can spread with or without visible symptoms. HSV2 typically infects the genitals, causing lesions to develop on and around the genitals and anus. This form of the virus is typically transmitted through sexual activity, although it can spread from mother to child during childbirth. Unlike HSV1, it's very rare for HSV2 to spread to the mouth and lips. This form of the herpes virus almost exclusively causes genital lesions. Like HSV1, many people with HSV2 have no symptoms and are unaware that they're infected. Between outbreaks, HSV2 remains dormant in the body. The virus primarily remains latent in the sacral ganglion, a group of nerve cell clusters in the lower spine. HSV2 is more common in women than in men because the virus can spread more easily from men to women than vice versa as a result of anatomical differences. When we look at the disease progression, HIV-1 most commonly produces oral herpes or cold sores. People infected with the virus usually go through an initial outbreak shortly after catching the virus. This is usually an intense outbreak that features cold sores and a variety of flu-like symptoms. An initial outbreak of HSV-1 can last for 2 to 3 weeks. After this initial outbreak, HSV-1 can reoccur for a variety of reasons. Some people with HSV-1 experience outbreaks every few months, while others only experience outbreaks after certain trigger events, such various kinds of stressful events, for instance. Many people with HSV-1 experience no symptoms at all. Although rare, HSV-1 can cause genital herpes. In this case, the virus infects the nerve cells in the lower spine and causes sores to develop on and around the genitals and anus, not on the lips and mouth. HSV-2 almost exclusively causes genital herpes. After becoming infected with the virus, people with HSV-2 typically go through an initial outbreak. The symptoms are similar to an initial HSV-1 outbreak, albeit localized to the genitals rather than the mouth and lips. The most common symptom of HSV-2 is the development of genital herpes sores, which can form on the genitals, in the groin, and the upper thigh area and around the anus. Initial HSV-2 outbreaks can include a range of additional symptoms such as headache, fatigue, glandular swelling, and nausea. Many people with HSV-2 mistake the initial symptoms for the flu before the genital herpes lesions become visible. Like HSV-1, the initial symptoms of HSV-2 outbreaks usually last for 2 to 3 weeks, although many people with HSV-2 do not experience any symptoms at all, which results in many people with HSV-2 remaining unaware that they're infected. Although primary infection with HSV is often inapparent or minor, there's some serious diseases that are caused by HSV infection. For instance, both types of HSV can cause encephalitis. Encephalitis caused by HSV-1 is rare but can result in significant brain damage or even death. Neonatal HSV, defined as infection in a newborn within 28 days of birth, is especially devastating. Untreated neonatal HSV has only a 40% survival rate, and even the early initiation of high-dose intravenous acyclovir therapy results in significant disability among survivors. Most neonatal infection results from exposure to HSV in the genital tract during delivery, although in utero and postnatal infections can occasionally occur. While most clinical management guidelines for HSV infections concentrate on women with long-established disease, the risk of transmission is significantly greater among women who acquire genital infection with HSV during pregnancy than among those who have long-standing infections and subsequently reactivate virus in the genital tract at term. Thus, while the number of infants born to women with newly acquired HSV at the end of pregnancy is much smaller than the number of infants born to women with established HSV-2, the much greater efficiency of virus transmission during the newly acquired genital infection accounts for the fact that 50 to 80% of neonatal HSV cases result from women who acquired genital infection near term. When a person gets herpetic eye disease, they can experience a variety of symptoms. These can sometimes occur in both eyes, but they usually affect one eye more than the other. Sometimes a person may also experience herpes sores on top of the eyelids. These may resemble a rash with blisters. The blisters will form crusts that eventually heal within about a week. If the herpes virus affects the cornea, the inside of the eye, or the retina, a person may find that their vision becomes reduced. Typically, eye herpes does not cause a lot of pain, even though the person's eye may look painful. A whitlow is a lesion on a finger or thumb caused by the herpes simplex virus. It's a painful infection that typically affects the fingers or thumbs. Whitlow is often contracted by healthcare workers that come in contact with the virus. It is most commonly contracted by dental workers and medical workers exposed to oral secretions. It is also often observed in thumb-sucking children with primary HSV-1 oral infection through a process called autoinoculation, and in adults aged 20 to 30 following contact with HSV-2 infected genitals. Symptoms of herpetic whitlow include swelling, reddening, and tenderness of the skin of the infected finger. This may be accompanied by fever and swollen lymph nodes. Small clear vesicles initially form individually, then merge and become cloudy. Associated pain often seems large relative to the physical symptoms. The herpes whitlow lesion usually heals in 2 to 3 weeks. And lastly, there's the problem of reactivation in people who are immunosuppressed. In immunosuppressed people, outbreaks from HSV are more frequent and more severe than those who are immunocompetent. Herpes simplex 1 establishes latency preferentially in the sensory neurons of peripheral ganglia. A variety of stresses can induce recurrent reactivations of the virus, which spreads and then actively replicates to the site of primary infection, usually the lips or eyes. Viral particles produced following activation can reach the brain, causing a rare but severe form of diffuse acute infection, namely herpes simplex encephalitis. Most of the time, this infection is clinically asymptomatic. However, there's a growing body of evidence that indicates the cumulative effects of repeated mild HSV-1 brain infections may result in neuronal damage similar to that found in neurodegenerative disorders such as Alzheimer's disease, the most common form of dementia in the elderly. This is a very interesting area of research, but it's a fairly new finding. Antiviral therapy may have a dramatic impact on the first clinical episode of HSV. Antiviral therapy includes 3 preferred nucleoside analog oral medications: acyclovir, valacyclovir, and famciclovir. They exert their anti-herpes activity by selectively inhibiting the HSV DNA polymerase. There are several situations when prescription antiviral medication is recommended, and almost all apply to cases of genital herpes infection. The prescriptions used for herpes infection are all antiviral medications, and like the over-the-counter antiviral cream Abreva, they inhibit proliferation of the virus, but they do not rid the body of it. So they're not cures. Most patients with symptomatic genital HSV-2 infection experience recurrent outbreaks. Antiviral therapy for recurrent genital herpes can be administered either episodically to ameliorate or shorten the duration of lesions, or continuously as suppressive therapy to reduce the frequency of occurrences. Taking herpes medication when you do not have symptoms has been shown to reduce the risk of sexual transmission to a partner. Docosanol is a saturated 22-carbon aliphatic alcohol with antiviral activity. Docosanol has a distinct metabolism of action that inhibits fusion between the plasma membrane and the herpes simplex virus, thereby preventing viral entry into the cell and subsequent viral activity and replication. So it's preventing attachment and penetration of the virus into the host cells. This is used topically in the treatment of recurrent herpes simplex episodes, recurrent cold sores, and relieves associated pain and can help heal sores faster. Studies have shown that daily therapy with either acyclovir, famciclovir, or valacyclovir significantly reduces subclinical shedding of HSV2. Available data suggests condoms can play significant roles in the overall strategy of preventing HSV acquisition and transmission, but it's important to note that the impact is only modest. So, of all of these, well, first of all, you need to disclose your HSV status. That's an ethical consideration. So you need to disclose that to your partner. But probably the most effective prevention would be using the suppressive antiviral. And so let me take a moment to tell you a modern virology love story. I have a friend who has HSV2, and she'd been divorced for a while. She met this guy, really liked him, thought that the relationship was starting to heat up. And she talked to me about what to do about her HSV status. And I told her that she had to disclose. She had to tell this guy about her status. It was the only right thing to do. And I told her, don't waste time. She'd been putting it off. I said, just, pull the Band-Aid off, because if it's going to be a deal breaker, you might as well find out now. So she told him. She called me up shortly after and said, he has HSV2 also. So it was no longer an issue. So there you have it. Being honest is always the right way to go. Now let's move on to varicella zoster virus. With this infection, chickenpox represents the initial infection, and shingles would represent when a person has a recurrence from a latent infection. Now, it isn't clear how the chicken got connected with the pox in the name of this disease. The Oxford English Dictionary attributes the chicken to the non-threatening nature of the pox. In other words, the pox was cowardly or chicken. Kind of stupid. Other people have guessed that the chicken stems from the blister's resemblance to chickpeas, or less charitably, to the fact that an infected person looks like he or she has been pecked over by a chicken. At any rate, chickenpox is the commonly used name, but again, this is for the initial infection with shingles, or sometimes they use the term zoster, being the recurrence when you have an reactivation of the virus. So let's look at the initial infection first, chickenpox. So chickenpox is a disease that manifests itself with a fever and rash that may contain as many as 500 blisters with the potential to spread over the entire body. The varicella virus is highly contagious and spreads easily from person to person by direct contact with chickenpox blisters, or airborne when someone has chickenpox and breathes or talks. Chickenpox may be contracted 1 to 2 days before the rash is visible and until scabs have formed on all blisters. Chickenpox develops within 10 to 21 days after contact with an infected person. Since 1995, the varicella vaccine has been available and is FDA cleared for use in healthy children 12 months of age or older, and adolescents and adults with no evidence of having had chickenpox in the past. A history of chickenpox is considered adequate evidence of immunity. However, there is a blood test to test immunity in people who are uncertain of their history with the disease. But again, it's as is common with many of these diseases. Normally it's self-limiting, but there are potential complications that can occur. Complications are more common in adults, and if a pregnant woman develops a primary infection. Shingles, or zoster, is caused by the varicella zoster virus, the same virus that causes chickenpox. Anyone who's had chickenpox may develop shingles. After you recover from chickenpox, the virus enters the nervous system and lies dormant or latent for years. Eventually, it may reactivate and travel along nerve pathways to your skin, producing shingles. But not everyone who's had chickenpox will develop shingles. The reason for shingles is unclear, but it may be due to lowered immunity to infections as individuals grow older. Shingles is more common in older adults and in people who have weakened immune systems. A person with shingles can pass the varicella zoster on to anyone who isn't immune to chickenpox. This usually occurs through direct contact with the open sores of the shingles rash. Once infected, the person will develop chickenpox, though, not shingles. Remember, shingles is the reactivation. It can only occur after someone has had an initial primary infection. Chickenpox can be dangerous for some people. Until your shingles blisters scab over, a person is contagious and should avoid physical contact with anyone who hasn't yet had chickenpox or the chickenpox vaccine, especially people with weakened immune systems, pregnant women, and newborns. Anyone who's ever had chickenpox can develop shingles. Most adults in the United States had chickenpox when they were children before the advent of the routine childhood vaccine that now protects kids against chickenpox. Now, there are some serious complications for chickenpox. This includes post-herpetic neuralgia. For some people, shingles pain continues long after the blisters have cleared. This condition is known as post-herpetic neuralgia and occurs when damaged nerve fibers send confused and exaggerated messages of pain from your skin to your brain. Shingles in and around an eye can cause painful eye infections that can result in vision loss. And depending on which nerves are affected, shingles can cause an inflammation of the brain or encephalitis, facial paralysis, or hearing or balance problems. And if shingles blisters aren't properly treated, bacterial skin infections may develop. Epstein-Barr virus is a gamma herpes virus that infects over 90% of the human population worldwide. It's usually transmitted between individuals in saliva and establishes replicative infection within the oropharynx, as well as a lifelong latent infection of B cells. Primary EBV infection generally occurs during early childhood and is asymptomatic. However, if that primary infection is delayed until adolescence or later, it can be associated with the clinical syndrome of infectious mononucleosis, an illness characterized by fevers, pharyngitis, lymphadenopathy, and malaise. EBV infection is also associated with the development of EB-associated lymphoid or epithelial cell malignancies in a small proportion of individuals. In some cases, EBV primary infections can lead to complications, some mild and some serious. These include rupture of the spleen. For instance, after a person's diagnosed with mono, they're usually told not to participate in contact sports for several months to allow time for the spleen to recover. Anemia can occur, thrombocytopenia or low platelet count, hepatitis, myocarditis, and various conditions affecting the nervous system, including encephalitis and meningitis, can all occur. EBV infection can increase the risk of developing certain rare cancers. This is because mutations in cells infected with EBV can lead to dangerous changes. Some types of cancers that are associated with EBV include nasopharyngeal cancers, Burkitt's lymphoma, and Hodgkin's lymphoma. EBV-associated cancers are uncommon, particularly outside of Africa and some parts of Southeast Asia. Experts are still trying to identify these specific mutations and why EBV infection seems to cause them. But overall, it's estimated that EBV infection contributes to only about 2% of cancers worldwide. EBV has long been thought to be linked to autoimmune disorders such as lupus. Experts believe that EBV may cause changes in the way some genes are expressed. This altered gene expression could increase your risk of developing an autoimmune disorder. One recent study found a potential link between EBV and an increased risk of developing lupus. The study's authors believe that the same mechanism linking EBV and lupus may also link EBV to other autoimmune conditions, including multiple sclerosis, rheumatoid arthritis, celiac disease, inflammatory bowel disease, and Graves' disease, and several others. Still more research is needed to fully understand the potential link between EBV and autoimmune conditions. A recent study looked at the rates of EBV infection in more than 700 people, both with and without schizophrenia. Those with schizophrenia had higher levels of antibodies to some EBV proteins than those who didn't, suggesting that they had an unusual immune response to the virus. The researchers also found that participants with genetic risk factors for schizophrenia, as well as elevated antibodies, were over 8 times more likely to have schizophrenia than the control group. Further research is needed to study any possible link between EBV infection and schizophrenia. Cytomegalovirus, or CMV, is a virus found throughout the world that infects between 50 to 80% of all adults in the United States by the time they reach the age of 40. Most people who acquire CMV as children or adults display no signs of illness, or they have mild symptoms such as fever, fatigue, and tender lymph nodes. People with a compromised immune system may have more severe forms of infection involving the nervous system. CMV is most commonly transmitted when infected body fluids come in contact with the mucous membranes of an uninfected person, but the virus can also pass from mother to fetus during pregnancy. For most people, CMV infection is not a problem. However, 2 groups of people are at high risk of neurological or other severe symptoms that may lead to long-term effects. So, first group would be unborn infants whose mothers have CMV infection. CMV is the most common congenital infection in the U.S. Most infants will have no permanent health consequences, but a small number will have long-term neurological conditions such as hearing loss, visual impairment, seizures, or disabilities. The highest risk of these severe effects on the fetus is for those born to women who acquire CMV infection for the first time during their pregnancy. The risk is much lower for women who have had CMV infection in the past before their pregnancy. The other group of high-risk people would be immunocompromised individuals. CMV infection may be severe in solid organ or blood cell transplant recipients, people with untreated or end-stage HIV or AIDS, or others with altered immune function. Infection may affect the brain, spinal cord, eye, or other organs such as the lungs or intestinal tract. In addition, transplant recipients may develop organ rejection or graft versus host disease associated with CMV infection. I've had some firsthand experience with this. Between my master's and PhD, I worked for a while as a research assistant in the surgical pathology unit at the University of Cincinnati Medical School. And they performed kidney biopsies for kidney transplant individuals from all over the city of Cincinnati. And my job was to go out and collect up tissue samples taken during a biopsy from these patients who were being monitored, and then I'd bring them back to the lab, and various types of tests were run to look for any kind of pathology. And I was in charge of doing the frozen sections. And the first thing I would do after I sliced up the sections, made my slides, is I would do a quick stain with methylene blue and look at it under the microscope. And if I saw allied inclusion bodies, I knew that it was an active CMV infection. And you can see very clearly right in the middle of that slide at the top what those ally inclusion bodies look like. So that was an indication that this person who was receiving immunosuppressive drugs had a reactivated CMV infection, which would put the transplant at risk. Human herpes virus 6, or HHV6, infects nearly all humans, typically before the age of 2. The acquisition of HHV6 in infancy is often symptomatic, resulting in childhood fever, diarrhea, and roseola. This virus has shown activation in transplant patients and has been found frequently in patients with neuroinflammatory diseases such as multiple sclerosis. It's also been suggested as a cofactor in the progression of HIV to AIDS. Human herpes virus 7, or HHV7, causes ubiquitous infections in early childhood, yet primary infections are rarely recognized. Thus, there's very little known about the epidemiological characteristics and manifestations of acute HHV7 infections. Human herpes virus 8, or HHV8, seroprevalence among the general population in the United States is under 5%. The seroprevalence is greater among men who have sex with men, where it can range between 20 to 77%, regardless of HIV infection, and is also higher in certain Mediterranean countries, where it can range from 10 to 20%, and in parts of sub-Saharan Africa, where studies have found it to range between 30 and 80%. HHV8 is etiologically associated with all forms of Kaposi sarcoma. The precise pathogenesis is unclear, even though seroconversion to HHV8 precedes the development of these tumors. So, there you have it, gang. You've survived virology.